Yeah, thank you. Thank you, CSI and Somshila, for the opportunity. Uh, I think I've been asked to cover the cornea and inflammatory diseases. I don't wish to be comprehensive. I thought I'll focus mainly on peripheral ulcerative keratitis, which is a very pertinent topic. So, what is peripheral ulcerative keratitis? It is basically a destruction of the cornea associated with limbal inflammation. And as it is taught to you, you can see this overhanging edge. So you can actually go inside, like with the 26 gauge needle, you can go underneath that overhanging edge and see that some part of the cornea is distracted. If you take an OCT, you can see the overhanging edge. And whenever there's an active infiltrate, it will appear more hyperreflective. That white color would be there. So what's the importance of PUK? PUK can be the macro-ulcerative PUK. That is what I mean about PUK. It can be micro-ulcerative, which is staphylococcal marginal keratitis and stuff like that, which is bothersome but quite innocuous. But macro-ulcerative PUK and necrotizing scleritis is a much more severe form of vasculitis. If it is not treated properly, more than 50% of the people will die within 5 years. It's your responsibility to pick up the case and actually treat the disease process. So it's, as an ophthalmologist, it's our responsibility to pick up that case. And if it is treated, the most of the people, more than 90% of them, can easily be saved. So whenever you encounter a PUK, you have to do a systemic evaluation for connective tissue disorders. At least the basic collagen workup you should do. The inflammatory markers, ESR, CRP, ANA, and RA factor. I think the dermatologists would add much more to it, but at least this much we should do. And it makes sense to look at the other parts of the eye as well, even the other eye. If you have evidence of scleritis, like if there is a choroidal show, or if there is very severe dry eye in either of the eye, and if you see these mucus clumps, debris, filaments and all that, it is very likely that you're leading with systemic disease. And sometimes the eye would be white and then you can still have these choroidal show, as you see here. Sometimes you don't see scleritis, but you can see evidence of sclerosing keratitis as seen as whitish discoloration of the peripheral cornea. These are all telltale evidences that there is some other inflammatory process happening in the body, in the eye. So the treatment of the disease is basically the treatment of the underlying condition. Our aim, whatever ophthalmic treatment we give, is only supportive. So the treatment has to be tailored, like systemic steroids has to be given. If it is a very severe form of disease, you have to pulse the patient. That is, you have to give IV methylprednisolone and get the disease process under very good control. And sometimes you have to use IV cyclophosphamide also. As an ophthalmologist, we have to use, basically our treatment is supportive, as I said before. We have to use liberal preservative-free lubricants. And it's a good idea to put in a plug so that the tear film is much more in volume. Once the disease process is under control, we have to suppress the ulceration and provide tectonic support by giving peritomy and cyanocolate glue. So it's very important that you distinguish between Murren's and PUK. In Murren's, it is a localized autoimmunity. It's usually the cornea-associated antigen against with the antibodies working against. So as I said before, the difference between Murren's and PUK is that Murren's, the treatment is topical steroids essentially, while in PUK it is systemic immunosuppression. So depending on the disease, like if it's vaginous and very severe form of vasculitis, you have to admit the patient, pulse the patient. Quite often you have to give methylprednisolone also. And most of the conditions like rheumatoid arthritis, somewhat moderately severe, you can just give systemic steroids 1 milligram per kilogram and it should be done. In Murren's, it is topical steroids. Then you switch up the treatment to peritomy plus glue and then systemic steroids. And then if it is not working, then you have to go for systemic immunosuppression. So both Murren's and PUK can actually rip across the cornea like this in certain situations. I think I'm not going into the details now, but I think in very severe form of disease, you can use the biological agents like infliximab, rituximab, and adalimumab. So I'll just take two examples. This is a patient who was an auto driver who came with a peripheral ulceration of the cornea, showed about 80% thinning. Basic collagen workup was almost normal except a slight elevation of the CRP. So we gave topical steroids thinking that it's Murren's in young. and we saw that there is necrotic tissue in the center part of the cornea when we added the systemic steroids. There was some response to systemic steroids in the initial period, but later there was more necrosis happening in the center. We had a differential of secondary infection versus worsening of the disease, took the corneal scraping, microbiology, and in the same sitting did the peritomy and tissue adhesive plus bandage contact lens, after which the disease settled down. But once the glue got dislodged, the disease came back again. And we restarted steroids with little effect, but then we had to put him on a repeat conjunctival resection plus DAPACL. Then this time we started steroids, the methotrexate also, and the patient has been on a good follow-up. So this patient has completed 3-year follow-up now on a very minimal dose of methotrexate, just 7.5 milligram once a week, and is doing pretty well. Case number 2, a more severe form of disease, a 45-year-old lady with vaginous granulomatosis who had bilateral CSOM and had chest lesions as well. So at presentation, she had this PUK along with scleritis, and in fact, she had an optic nerve head granulomatous process, and with which she lost vision in one eye. The other eye had again severe scleritis and PUK. So because she lost one eye, we had to admit the patient, and this patient, despite the best treatment by the rheumatologist in the initial period, she was on maintenance steroids of 20 milligram a day, Azoran more than 100 milligram, and mycophenolate more than 3 grams a day. Still the patient was not responding to treatment. The disease process was happening. So we had to use a biological agent. We used rituximab, and after 3 doses, the eye just quietened down. So it's very important to pick up the disease. When the amount of antibodies and cytokines are very high in the circulation, it's much more difficult to treat the disease. You have to use much higher dose of steroids, IVMP and all that, and quite often you have to use multiple doses of rituximab. But if you pick it up early, once the disease is early in the process, then you can treat it much more easily. So in the interest of time, I'm not going to the patch graft. Once the disease process is good and under good control, we can go for the patch graft. And if you do a patch graft, it is not necessary you have to be limited by the roundness of the trephine that you have. You can do a customized patch graft. In this, I have taken a quadrangular shaped patch graft. I just cut a bit of our drape. It is cut in that particular shape, and that was used. And 3 or 4 years later, patient came for the cataract surgery, and the graft was looking nice. So I would like to conclude saying that it's very important to identify PUK, not only for the eye, but for the life of the patient. And prompt immunosuppression is a must, and you should team up with the rheumatologist to do that. And surgical repair, as far as possible, should be done after control of inflammation as much as possible. Thank you so much.
Thank you, sir. That was a wonderful talk, and on that vast topic that you covered so nicely. Sir, I have one question. Sometimes we have very severe cases of PUK where 360-degree melting has happened, and you have a central part cornea which is intact and sitting there. So how do you manage these patients?
Okay, so we obviously will take the rheumatologist's opinion and tease the disease process, and usually the destructive process of the cornea stops there. Then depending on the astigmatism you can do, like if there is no much of astigmatism, you can, just for the tectonic support, you can do a multi-layered amniotic membrane. That would be my preferred strategy. But if it is so severely ectatic, you have to go for multiple crescentic peripheral lamellar grafts. So sometimes you have to use 3 or even 4 grafts, and then only you can tackle it.
Thank you, sir. Anybody wants to ask any questions? As such, we are running short of time. But any questions? Okay, so
yeah, it is preferable to do because these conjunctival vessels carry the antibodies, and when you have an antigen-antibody interaction happening in the peripheral cornea, which leads to complement activation and collagenase activation and the disease process, so it's better to block it. One, mechanical blockade that you're doing with the cyanoacrylate glue. Second thing, you are blocking the antibodies from reaching the circulation by doing a peritomy. It's advisable to snip away, take away some amount of tissue also. Yeah, I think, see, if it is so much of a perforation that the tectonic integrity of the patient is compromised and it's about to perforate, then only you have to think of a multi-layered amniotic membrane. We would, in the first step, would prefer to do a glue. And usually, quite often, most cases, it will get settled down with the glue itself.
So would you suggest Tenon patch in patients who have PUK with autoimmune diseases, because it's an inflammation that is going to involve the eye and going to involve the entire tissue? So Tenon patch in autoimmune disorders with PUK? Or
Yeah, I have used tenons, but not exactly in these cases, but it should also work.
Okay, sir.
Somshil, any
we'll
comments on
end the
that?
session because we are over time. Sorry.
Yeah.
Excellent talk, I agree. And thanks